a very rainy day today, and I know there's people trying to get in and out due to the unexpected issues, I know, on the highway and throughout. So I hope everyone is safe and is making it through the weather, because we do have a packed agenda, some exciting news and also some challenges to report. As this is Infant Mortality Month, it's a month we look forward to celebrating every year our efforts to reduce infant mortality in Oklahoma, and then seeing that work come to fruition and what the latest data does report in relation to those different measures and items that show the progress that's being made in Oklahoma. So we have some ads and items that will be displaying throughout the month on Cox Media and other avenues. So please check them out as you see them come through with the Preparing for Lifetime logo. And yes, I love this picture. I think it's speaks definitely to our babies and how much they mean to us and their importance in Oklahoma. Also, I did want to state before we turn it over that the infant mortality this year, while there are definitely some concerns and some room for improvement to continue, there is some really overall encouraging news in our latest report. So we look forward to sharing that with you and moving forward in Oklahoma. In addition to being Infant Mortality Awareness Month, it is also kind of tied to that Newborn Screening Awareness Month and Child Passenger Safety Awareness Month. Other items that we definitely promote for our babies to have the best chance at being able to celebrate that first birthday, which is so important, with their families. So we're going to go ahead and move into our presentation. So we have, first of all, we will have our infant mortality in Oklahoma data presentation by Benitha Kunnel, who is the Administrative Programs Manager over MCH Assessment. And that is going to be followed by our brand new Maternal and Child Health Data Portal. You're going to be seeing a brief kind of display demonstration of the portal, how it works, and how you can get the data and information you need for your areas and to, of course, improve infant mortality reduction and other items throughout the state. So Benitha, I know everyone is waiting now to hear from you in relation to what does the data say in relation to infant mortality in Oklahoma.
Good morning, everyone. It's that month again, as Joyce said, we are going to be talking about infant mortality. So I'm going to present some of the slides that were presented last year, so you can also compare to what is going on. So why is IMR or infant mortality rate so important? As you can see, it's a very crucial and a sensitive indicator of the population's health. So this is an abstract from CDC, which says it. Before I start, can you all see my presentation?
Benitha, we can see it, but if you can put it on the display, the little thing that looks like the screen down at the bottom, then it will. Your slide will take up and it won't show the ones to the side at the same time. There, you got it.
Okay, sorry. I should have. Okay. So this was my slide that I was talking about. It's a very crucial indicator. It's a very sensitive indicator. That means slight changes could bring about big differences in the rate itself. So. These are some of the definitions. Infant death is the death of a newborn until 364 days, prior to 365 days. That's how we define infant death. A neonatal death is less than 28 days, which is 0 to 27 days. Post-neonatal death is 28 to 364 days, and the mortality rate itself is the number of infant deaths per 1,000 live births. So this is a slide you have seen over the years. It compares Oklahoma's infant mortality rates for individual years to the US. And you can see we have quite a bit, a small difference. And in 2022, the US rate was 5.5, while we had 6.9. But I have to reiterate, the individual years for 2021 was also 6.9. So we have held steady. This little hump here is the 2020 rate, and we all know the pandemic impacted registrations, and we think that probably is what happened there. The rate was 6.0, and some influence due to the pandemic. Okay. This is the 3-year rate to smooth out all the fluctuations in the infant mortality individual years, and you can see this decline. This is a very encouraging chart. We are slowly and gradually decreasing infant mortality rate. We are at 6.6 for the years 2020 to 2022. This was the same rate for the prior 3 years, 2018 to 2020. So this is an encouraging slide because we are showing a decline. So this is the next slide, which looks at opportunity for intervention. I used to show just the neonatal and post-neonatal deaths, but I'm also looking at in terms of where are opportunities for intervention. You can see nearly 2/3 of the infant deaths happen in the neonatal period and 1/3 in the post-neonatal period. And looking at the top causes of death, preterm births is the top cause for neonatal deaths, while sudden infant death syndrome is for the post-neonatal. Both these causes, we have some interventions in place. Okay. Infant mortality by race and Hispanic origin. When I describe this slide, I have to mention some changes that has happened to race recoding. In 2009, Oklahoma revised its race enumeration to include the multiple races. And at the time, the National Center for Health Statistics, or NCHS, developed a methodology called Race Bridge, which would they had a modeling process that they would assign races to a category that would help us compare to the previous race enumeration. So we were using those bridge races until 2021, and then NCHS retired the bridge race. So, but however, they provided us with a recoded race field, which impacted certain population. You will see that that it impacted certain population, specifically the American Indian population, and which also increased the percentage of birth and death and among the other and multiple races. We were looking at this data a little bit in detail to see what was the impact. We are still learning. Okay, we are trying to understand what is the real impact of this race recoding, because the rates might look different. Now we have infant mortality of the American Indian population on par with the white population. So we looked at the other and multiple race, and we found that for nearly 74% of the births in multiple and other races are also white. Okay, and while 64% of the infant death are also American Indian. So there is an impact to that American Indian population. That's, you see the rates have gone down, but the other and multiple races have gone up. You can see here that I'm comparing it to 2019 because of the issues with the 2020 registration. So you can see the other and multiple races have increased by 48%, while the American Indian population have gone down by 35%. So some of this is attributed to that race recoding, but we have made progress in decreasing the infant mortality rate of almost all the races and ethnic and Hispanic origin. Hispanic origin, I have to take that back. It has increased, but then the birth rate is also increasing for the Hispanic population. This is a very complicated graph. I agree with that. It is too. You may not be able to understand, but you can see the trend. The trend is there, and I've indicated with 2022 the race recoding has changed, and that has showing the American Indian the graph to going on par with the white population. Okay, this is something I wanted to look at. I mean, this is slightly different from the handout you have because I added an aggregate of 2020 to 2022 years to see. I found that as I said, the American Indian population, the post-neonatal deaths among American Indians were always higher, and with this new recoding, I can see that it is sort of gone down, and which is being taken up by the other and multiple races. But this shows you where the neonatal deaths are higher and where the post-neonatal deaths are higher, which population has either of these imbalance. So, and where interventions can be applied. So if you look at this, the non-Hispanic Black population has a very high neonatal deaths. It's 7.3 per 1,000 live births. They have the highest, followed by the other and multiple race and the Hispanic population. But the post-neonatal death is also higher among the Black population, which is 5.2 per 1,000 live births, and the other and multiple race seems to have a very high post-neonatal death. Okay, this is again with the race and looking at the race disparity ratios compared to the white population. You can see the non-Hispanic white population has 63.4% of the population, 54% of the births, but only 42 or 43% of the deaths. But you compare that to the Black population, you can see when it has around 7% of the birth and population, 15% of the deaths are among the non-Hispanic Black population. The Hispanic is also higher in terms of the relative proportions of their birth and population. The next, the Hispanic population is on par with birth and population, but their infant death is overall is 33% of overall deaths, while the other and multiple races are almost 13%. And I said that what I've been talking about, this imbalance was created by the recoding. We are going to study this further, and probably we have to come up with a solution to this to accurately define where some of these populations should be assigned to. Okay, this is the slide that we usually report on the top five rankable causes of infant death. This has remained almost the same every year. And the congenital anomalies at the top, followed by preterm birth, sudden infant death syndrome, injuries, and maternal complications. They turn to be almost the same, so with slight difference in the percent of birth. Almost 23% belong to the congenital anomalies. This is the top 5 causes of neonatal deaths. Again, neonatal deaths are mostly due to preterm births or anomalies and maternal complications. Post-neonatal death, you see sudden infant death syndrome coming to the top with unintentional injuries and anomalies. So you can see where interventions could be applied, and homicides also in the list this time. This is the top 3 rankable causes by race, and the main races and Hispanic origin. So you can see non-Hispanic white population has the more common, the anomalies, preterm and sudden infant death syndrome. But if you go to Hispanic Black, you can see the preterm birth comes at the top with unintentional injuries, followed by sudden SIDS. So you can see the rest, how it compares to the other population. This is by county. There's not much of a difference. I was comparing to the last 5 years. We have some of the southern counties and northeastern counties do tend to have higher infant mortality rates. This is a graph that the darker shades show higher rates. This is the data that this is new to this slide set that I usually send. This is linked data. We linked the birth data and the infant death data. This is for years 2019 to 2021. I'm linking it to the birth to see at what gestational ages and the birth weight. And you can see like 47% of all infant deaths are among infants who were born before 32 weeks. Okay, and 37 weeks and over, there's almost 34% of the death. Those are the post-neonatal death that you often see. And below that, you see the birth weight, less than 1,500 gram. 47% of the births are attributed to babies born too young. So, but the infant mortality rate itself is very interesting. You'll see for less than 32 weeks, 169.2 per 1,000 live births, while you compare less than 1,500 grams, it's 198. So being of smaller weight is more dangerous for a new baby than the gestational age itself. These are the work group measures for the Preparing for Our Lifetime initiative. We have these measures that we have been tracking since the inception of this initiative. Some of the data sources for this slide comes from both the vital statistics and the PRAMS and TODS. You can see this is a very encouraging slide because you'll see all of those measures have made significant improvements. Probably the only one missing is the preterm birth. So you can see unintended pregnancies has gone down by like 24%. First trimester prenatal care has improved by 7%. Teen birth rate, this is the most encouraging of all, like 70% of decline in preterm births. Teen birth rates. Preterm births have increased by 4.6%. This year, it's better than last year. We had 11.9 last year. This year, we have improved to 11.3%. Smoking during, this is another indicator that we have made big strides in. 68%. This comes from the PRAMS data set. And breastfeeding, ever breastfeeding or initiating breastfeeding, 11% improvement. Safe sleep, it's also improved. Postpartum depression screening, that is an effort that we have in MCH, increasing screening for postpartum depression, and you can see the result, 74% improvement in screening. So it's the same work group measures by race and Hispanic origin, and you can see it's a little crowded, but you can still see where we are making improvements and where we need to work on. I'm not going to read all of it, but since you'll have the handouts with you, you can take a look and see where some of the greatest improvements have been. These are some of the measures that we track, which are either risk factors or factors that show our improvement. So these are preterm births. You can see this is one slide that shows us below this the US rate, and we were at 11.3 for 2022, and we don't have the national rate yet. In 2021, we were 11.9 with a national rate at 10.5. This is the low birth rate. You can see we are on par, almost nearly on par with what the US rate is. We were at 8.7 in 8.3 in 2022. First trimester prenatal care, as I said, this has improved over the years. Much improvements you can see. We are at 71.8% in 2022. So this is also an indicator that shows the healthcare available to mothers in the state. That's the last of my slide. Do you all have any questions for me?
At this time, if you have any questions, you may please feel free to unmute your mic or put it in the chat.
Thanks, Benita, first of all. While others are getting ready to ask their questions, I just want to say thank you for sharing this presentation with everyone and letting us know where we are in relation to infant mortality in Oklahoma. Additionally, I think the really good news and takeaway from this and encouraging is that, like I said, while there's challenges, you can certainly see that we are at our lowest historical rates. We've maintained that from last year at the same amount, which is really good news considering that we've just been through the pandemic and all the challenges that that pandemic through 2020 to 2022 had. So I think it is very encouraging news and that your efforts are making a difference and we are seeing improvement in infant mortality in Oklahoma, and we need to continue those efforts full speed to continue to make further improvements as needed. So Barbara, I saw you briefly, did you have a question?
I did. I'm sorry, my computer shut down last night and then it took forever to start up this morning. So I missed the beginning. Are we going to receive these slides?
Kamisha will be sending it out, right? I mean.
So the data has not been finalized yet. So we'll be able to share those that have been finalized. And as soon as it is finalized, we can probably share the rest, but it is provisional data at this time. So we probably will not be sharing the presentation until the data is finalized, which should be very soon. But that's the information in that.
Okay. I'll email you because I'll need some of these for our summit. But if we do receive them, I didn't know if some are going to be sent. It was hard for me to see the color differences of the lines. So in the line graphs, if you could change the color so it's more obvious as to which line is associated with which category, if we do receive those. So my old eyes couldn't see the difference. I was like, wait, which one of those is the darkest? So thank you.
I would also like to add, we do have a new MCH assessment email. So for any data requests, we would like everyone to send it to MCH assessment, all one word, MCH assessment at health.ok.gov. And that helps the assessment team tracks what data requests are coming in. Thank you.
Thank you so much.
And note about that line color, it depends on the resolution of your computer too. I mean, so I will try to change the colors into very different so you are able to see, but it also depends a little bit on the resolution of your computer.
Right. It's just hard, sometimes the programs just make them like all within the same color scheme. They're just varying shades, and those are harder to see than if they're different colors. So thank you so much. This is very encouraging news.
Yes, and if the work group core measures that were shared, like I said, there was improvement in every area this year, let alone the marked improvement since it began in 2009. So another item we have to celebrate. And that has, like I said, to do with our core work groups, and those measures were based to measure the improvement on those items that were felt could make a key difference in decreasing infant mortality. Are there any other questions for Benita?
There's another in the chat. For those that joined late, can you repeat the overall infant mortality rate?
For 2022, it is 6.9. It was the same rate for 2021 too.
And then the 3-year rate is 6.6.
6.6, yeah.
For 19 to 2022.
No other information in the chat besides a good job on presentation and the appreciation and acknowledgement, including multiracial races in our data. That's all we have.
All right. Well, thanks again, Benita, for sharing, and thank you everyone for all of your work in this regard. That's given us items to celebrate in relation to more infant lives being saved. Okay, so now we're going to move on to our next agenda item, and that is Benita as well as Cynthia Bates, who is our State Systems Development Initiative analyst, are going to share some additional exciting news in relation to our maternal and child health data portal. So I'm going to turn it over to you, ladies.
Okay, we are so excited to introduce this MCH or Maternal and Child Health Data Portal to you. Before I start, I want to introduce a new staff to assessment. April Lopez, if you want to say hi, she joined assessment as the PRAMS and TOTS analyst, which is a position I used to hold in the past. So she will be helping with all of our analysis efforts related to PRAMS and TOTS. Now to the data portal. So this is we have discussed creating a system that where we can, it's like a one-stop shop place for any data related to MCH. That was the initial goal, and so this has come to fruition, and the entire assessment team, this was a combined effort for sure. Each and every staff contributed to the development of this portal. Staff had to learn the Tableau software to develop the interactive dashboards. So, you will see that it spans all the domains of MCH. So, it is kind of similar to Acacia, but at the same time, very different. It's only for maternal and child health with aggregated data, and if any of after the presentation, if anyone needs an orientation or a walkthrough, we are more than willing to help or happy to help you walk through this, navigating this this data portal. So with that said, but you'll also see that some data systems are missing. It includes several data sources. The PRAMS and TOTS are missing because of the absence of the dedicated analyst to do that. But it is an evolving, it will grow. This portal will grow with other data systems coming into play. Now I will hand it to Cynthia.
Good morning, everyone. Can everyone hear me?
Yeah, we can hear.
Yes, okay. All right. So I will go into the how to access the data portal. All right, so there's three main ways to access the data portal. One, if you go online and you search for Oklahoma MCH data portal, it'll be one of the first links on there, like in a regular Google search. Another way is if you go to the OSDH homepage under health education and data and reports, you'll find the link here for data portal. And then the third way is if you go to the Maternal and Child Health Service homepage, here on the left, you will find the link for the MCH data portal. So this is just a quick snippet of the MCH data portal. It has some general information on the goal of the portal and some of the data sources available on the portal. There are three main buttons here on the home page that take you to different sections of the data portal. There's one that takes you to the interactive Tableau dashboards. And I'll go into each of these pages and explain it in more detail. And then another that takes you to MCH fact sheets, reports, and infographics. And then finally, a button that takes you to a web page with some list of external MCH data sources. All right, so first is the interactive dashboards. This is the main page for the interactive dashboards. It includes data portals for each of the MCH population domains. Most of these will be updated yearly, depending on when the data is available. For some of these, it won't be yearly. For example, YRBS, that survey is not completed every year, so that will not be updated yearly. Each of the dashboards contain a tab with technical notes that have relevant definitions and data sources. And as Benita mentioned, there's a few dashboards that we have not uploaded as of yet. For example, PRAMs and TOTS, they're not available, but we are planning on having those posted as dashboards here. So I will go ahead and go to this page and go through some of the dashboards. All right, so first, the perinatal reproductive health dashboard. Here in these little bullet points is the kind of information that we plan on including in each of these sections. Now, some of these are not uploaded yet, like PRAMs and TOTS, and here specifically women's health, maternal health, but it is a plan to add those in the future. Currently, in this section, we just have live births, infant death, and fetal death data. All right. So one thing to note is with these dashboards, they do not span the entire page, but if you go inside the dashboard and scroll, then you will be able to scroll all the way down to the bottom. And all of the dashboards are formatted in a similar manner. So at the top, you have these tabs that take you to the different sections. So here there's live births, infant deaths, fetal deaths, and then, like I said, all of the dashboards have a tab at the end for technical notes. This first tab for live births, it has some of the frequently requested data that we get with live birth data. And since it is interactive, as you see, you don't have numbers posted here or displayed here on this line graph. But if you hover over the individual dots, you will be able to see the numbers. So for here, it's birth rate for Oklahoma compared to the United States. So if you just kind of hover over, you see the numbers. And then here is a county map. And if you hover over, it has the county name and then what the birth rate is with the key here at the bottom. And above each of the graphs in this particular dashboard, it has the title, so the type of data that's provided, and then the year of data. So if you scroll down here, then we have fertility rate by race. And then here, the fertility rate by race over time from 2010 to 2021. And again, you can hover over the different dots. So it does look really messy because of the 6 different lines and all the colors, but you can hover over. And another option is you can just click on, let's just say you want to look at American Indian, Alaska Native. You can click on it and it highlights it for you. In this particular dashboard, it actually highlights everything that's related or linked to the race of American Indian, Alaska Native. So that just makes it a bit easier to look at and identify what the actual numbers are. Several of these charts also have filters, so you can filter by year. So this particular chart has percentage of births by race and Hispanic origin. And it goes back from 2010 to 2021. So you can look at what the percentages are for 2015 and just select the year. This one also has specific groups. So you can look at maternal age, let's say prenatal care, whether it was first trimester, second trimester, third trimester, no prenatal care. And then again, if you want to look at specific numbers, if they're not available on the charts, you can hover over it and see that. So here we have charts on maternal age, preterm birth, low birth weight. Here for preterm birth, you can see the trend over time. And since only 2021, that's the latest year of available data that's finalized. That's what's included. Once 2022 is finalized, we will include those numbers here. So for 2021, percent of preterm births was 11.9. Then here you can see by race. So you can kind of visually see which ones are higher just based off of race and Hispanic origin. And again, here there's a filter, so you can look back from, if you want to see what it was like back in 2010, and then compare it to 2021. And at the bottom, we have some of the general data sources that were included in this particular dashboard. Okay, then I'll go into infant deaths. And it's formatted here at the top of the dashboard, similar to live birth. So it has comparison to the United States, the county data by race and Hispanic origin. First section here is age at death. You can filter by years. And so in this dashboard, the infant death data, it's only in 3 years increments. So 2019 to 2021 and 2018 to 2020. That way, that kind of solves any issues of data suppression, especially when you look at it by race and Hispanic origin. So here you can see, so there's neonatal and post-neonatal death, what percentage were, different ages of death, and then also by age. So here you can kind of get a visual representation of, or comparison. So here, Asian Pacific Islander, 89% were neonatal compared to white, which is 62.7. Here we have the infant mortality rate by sooner care status and age at death. And if you filter, let's just say you go to 2015 to 2017, that data set is not available for those years. So it notifies you and says that that linked sooner care data is not available for the select years. Then this section has cause of death. Here on the left, the top 3 causes of infant deaths for all infants. Here on the bottom, you can filter by specific race and Hispanic origin. So if you want to look at American Indian Alaska Native, you see that number 1, it's SIDS, sudden infant death syndrome. Then if you want to look at other years, you can see how it changed. So back from 2013, 2015, that was listed as number 3. And then here on the right, you can select by 3 different causes of infant death and then look at it by race and Hispanic origin. So you have preterm related, SIDS, and SUIDS. So here you can see for 2019 to 2021, non-Hispanic American Indian Alaska Native had the highest at 36.7 compared to all at 21.5. And here, Asian Pacific Islander, the count's less than 5, so that data is suppressed and you will not be able to see any of those numbers. There's just an asterisk there. And then here at the bottom, we decided to include linked infant data, which is not available for all years. We only included years where the percentage of linked records was 95% or higher. And so with this data, you can look at infant mortality rate by specific characteristics that are only available on the birth certificate or birth records. So that would be gestational age, maternal age, education, and maternal BMI. As you can see, it's not surprising, infant mortality rate for preterm births is 32.8. And then when you look at it by maternal age, it's highest for the younger age groups and then over 35. And then again, here you have data sources and relevant data notes where it says field counts that are less than 5 are suppressed. Okay, and something that's relatively new that we didn't really report on much previously is fetal death data. So here at the top, there's the actual explanation of what fetal death is, which is also known as stillbirth, how it's calculated, and then also according to the CDC, specific risk factors for fetal deaths. And then it's formatted or organized similar to the other tabs where it has comparison to US, county, and race Hispanic origin specific. Some general overview of fetal death data. And so that information is available by birth weight. It has birth weight, gestational age information, so no linkage was required with this data. But here at the bottom, since some of these metrics are also available in the live birth data, we decided to compare it, fetal deaths to live birth data, just to see how it compares. And so, for example, pre-pregnancy hypertension, 6.3% of fetal deaths, but only 3.2% of live births. And the same for smoking status. And here you can filter by year, so you can look all the way back to 2013 to 2015 through 2019 to 2021. And then technical notes. Like I said, here it has all the definitions for the different variables that are available in the data portal, race, Hispanic origin options, lots of the rates that it has, how they're calculated. This specific one also has some ICD codes for causes of infant death. It also has just a general map of the Oklahoma counties in case you want to compare it to the county maps that are available in the different tabs. All right, so that is the perinatal and reproductive health dashboard. Now I will do a quick review of child adolescent health. So that has YRBS data and teen birth statistics. So right now, this is the only interactive dashboard page that has two dashboards on one page. So the top one is teen birth statistics, and then if you scroll down, it has the YRBS data. So here, there's teen birth rate available by maternal race and ethnicity from 2010 to 2021. There's also a table here at the bottom if you want to look at it, just the numbers. And then it also has the teen birth percentages. Oh, and I forgot to mention here at the top too, there's here for select topics you can pick by maternal age. So it has 15 to 17. And then here again, if you click on it, it highlights the table values as well. Then there's teen birth map by county. So it has the numbers here available on the left. And then you can see where one is suppressed here because of the small counts. And then the technical notes. And then down here is the YRBS data. It has, this is for the 2020, just 2021 data is available here. So here there's just some simple instructions on how to use the dashboard. First, you select the topic, and then you can select the corresponding questions. So the questions here change depending on what topic you pick. And then it shows you the data. And then it's also in table form at the bottom. There's also ACEs and PACEs information. So when you open the tab, it gives an explanation of the data. And then once you read it, you can hide that tab and then review the data. And again, if you hover over it, it has the numbers available. The same for PACEs and then technical notes. Cross-cutting systems building. Right now, we only have Medicaid, linked Medicaid data. So compare Sooner Care and non-Sooner Care. This is data from the linked Medicaid project. And so it has from 2015 to 2021. You can select the year and then select the specific measure that you want to look at, whether it's maternal age, trimester that prenatal care began. This one also has a county map and then the technical notes. Great. And then finally, the maternal and child health county profiles. And so this, we used to do a report, a county health report that had similar data. and it was a static report that was available on the MCH website, but we decided to convert it to an interactive dashboard. So here you can select what county you want to review. So we'll just pick Adair County. And so it has some general information here at the top for 2019 to 2021, the percentage of births by race, Hispanic origin. And the way this is organized, it has the highest towards the top. So when you change counties, so for this one, it changed to non-Hispanic white. You can also see that some of the data is suppressed. Since it is county data, the counts are smaller, and we do want to make sure we maintain that confidentiality. So there are a few counties where lots of these are suppressed when you look at it by race and Hispanic origin. And then we have some of this information which we downloaded from the American Community Survey from the US Census Bureau. So it's not MCH specific or vital statistics data. And then here we have some vital statistics data that you can filter by race and Hispanic origin. And again, if the counts are less than 5, then they're suppressed. Then we have a county map, and this one does have a table available if you want to just look at the numbers. And so how this one works, this map works a little different. So let's say you want to look at maternal age. So you can select multiple options. If you select, let's just say 24 to 44 years, the sum of all these subgroups is what is included here. So if you select all of these, then every county is going to equal 100%. And then technical notes for this one as well. And then one last thing. There is an option to download if you want to download a PDF, an image, or a PowerPoint. So if you see the data that you want and you want to save it, so you can copy it to a report or something, you can download the dashboard that you view into a PDF or to a PowerPoint. All right, so that's all for the interactive dashboards. And again, like Bonita mentioned, we're more than happy to have a call with anyone to go through each of these dashboards so that you become more familiar with it. And like I said, we're hoping to update it pretty soon in the next few months with the 2022 data, so it'll have updated information. All right, so another major part of this dashboard includes the fact sheets, infographics, and reports. And adding this made some changes to the MCH services websites as a whole. So on the page, you will find most, if not all, of the fact sheets, infographics, and reports that previously were kind of distributed and dispersed to the different sections of the maternal and child health web pages. So it's separated by fact sheets and infographics, which most of these in this section include 1 to 2 page documents, provides a snapshot of a topic, and suited for health professionals, community organizations, and the general public. And then you have reports that are more lengthy documents, often higher level, in-depth look at a topic. And they're separated in the same domains as the interactive dashboard. So there's perinatal reproductive health, so it has live birth data, reports, infant death, fetal death, maternal health, women's health information, child and adolescent health. So that has YRBS, teen birth statistics, and then cross-cutting systems building that has PRAMS, TOTS, Medicaid linkage reports for the most part. Most of it is includes PRAMS and TOTS reports. All right, so like I mentioned, there were some changes to the maternal and child health web pages because we ended up moving everything to the data portal. So on pages that used to have these reports or the links to these reports, this button was placed there or replaced those reports. So you see this on that page and it says related reports or documents are available at the data portal. And it has the link to the fact sheets, infographics, and reports webpage so that if people are used to, for example, getting the YRBS reports on that webpage, this button will be there and it will direct them to the data portal. Right. The final section includes external data sources. So we try to identify some other web pages that had MCH related data. So lots of it will be related or created by the Center for Disease Control and Prevention. So it has some National Immunization Survey, PERFIS, YRBS, PRAMS, and the general CDC Wonder database, which is where you can look at some population data by race. They also have national birth and infant death data there. And then the National Survey of Children's Health. There's several other listed, so I'll just open it. There's also the Maternal Health Task Force data catalog link is available there from OPQIC. And let's see, Medicare, Medicaid data. There's a link to the HRSA Title V website where you can look at previous Title V annual applications and reports. And then there's also a section that links to county health data that was, so there's a State of the State's Health online dashboard with county health data that was developed by the Oklahoma State Board of Health. And as we identify new sources and links, this webpage will be updated. All right. And that's pretty much all those three main sections. I think we have time for some questions if anyone has any about the data portal.
Like we've got several questions. So thank you, Cynthia, for that great presentation. And as you can see, we're very excited. This is something that we've been trying to get out for a while and have developed now and are excited to release. So you'll be hearing more information in relation to this, but we just wanted to give you a snapshot today so you could see what is available. And I see Becky's hand. You have a question?
Yes, I do. And this is awesome. I can't imagine how much work went on behind the scenes. This is kind of like having a baby and bringing it home from the hospital finally. So, where you were linking the infant mortality rate to data from the birth certificates, is it possible to add in a linkage to infant mortality and breastfeeding initiation, which is also on the birth certificate? So that's my first question. And then I have one more, the Sooner Care data.
Yeah, I can answer that question. So it's one of the data fields in the birth certificate. Definitely, we can add. We include, at this time, most often we include PRAMS breastfeeding rates. But if this is a priority coming from the birth certificate, we sure can add that.
That would be awesome. And then really a similar question with the linkage to the Sooner Care births. Can you do something similar link breastfeeding initiation by Sooner Care coverage, or Sooner Care births.
Yes, we can add that variable to it will be added to the existing portal. So yeah. We can do that. Thank you.
That would be awesome. Thanks.
I think there was one question in the chat. Is the data consistently updated, or is it updated annually?
So for most of the dashboards is updated annually, because that's when the most updated data is available.
All right. Please feel free to unmute your mics or add your question in the chat. As of right now, I don't see anything else. A lot of kudos to the work that has gone into this project. So very impressive. Something that they can really use, definitely use. Great work. I can tell you this is a labor of love. All right, we don't have any more questions at this time.
Right. Well, thank you, Kamisha. And again, thank you to the team for taking through that demonstration. Very helpful. And now we're going to move to our work group updates and the work that's been going on to help make these improvements. So we have the latest updates from our chairs of each group, and we're going to start with Safe Sleep. James?
Good morning, everybody. My name is James Craig, and I'm co-lead of this work group with Denise Cole, who's also on the call. Just wanted to say it's great to see everyone this morning. I think we've got some great news to share. Let's go to the next slide. So here's one of the things I'm very excited about because it's been a long time in the making. We have 3 new Safe Sleep hospitals certified through Cribs for Kids, and they are Integris Miami, St. Francis South, both certified as bronze level hospitals, and Choctaw Nation Healthcare Center is silver level certified. So you might ask, what's the difference? One of the biggest changes here between bronze and silver is that when it comes to the silver level folks, they have sleep sacks throughout the hospital and do not use receiving blankets at all. There's no blankets in the hospital whatsoever. So those folks within the hospital, of course, all these facilities are sent sleep sacks for the families to take home. But what I mean here, of course, is that when the actual facility is putting the babies in clothing, it is a sleep sack and not a blanket. So that's one of the biggest. There's a few other smaller differences, but that's one of the biggest ones. Anyway, congratulations. We're very excited about all these new hospitals getting their certification. Okay, so we have in September infant mortality awareness. Well, in October, right on the heels of that, is infant safe sleep awareness. Used to call it SIDS awareness. I don't like to do that as much anymore because it's not as comprehensive. Of course, SIDS is a subset of SUID, and I don't use that term very often in a wider group because a lot of folks don't know what it means. So SUID, of course, is the umbrella term for all sudden unexplained infant death, and that covers a lot of other categories beyond just SIDS. So last year, we utilized, and I took some screenshots to sort of give folks a visual indicator of what these look like. We utilized some videos that we partnered with Charlie's Kids for. For anyone who is not aware, Charlie's Kids is an organization dedicated to safe sleep. The founder of that organization lost their child through an incident where they passed away in an unsafe environment. And so we have Charlie's Kids puts out the only board book on safe sleep that I'm aware of. And these videos, there's, I think, 9 total, actually came out a year and change ago. And so we partnered with them because they're really fantastic. There's, like I think 9 total. And so we only utilized about half of those last year. So we're going to put some more of those out in October, of course, in addition to a press release and some social media components that utilize some of these images and the descriptions of safe sleep guidelines from our most recent Safe Sleep booklet, which was fairly recently put out as well. So that'll be coming up in October. You should see those coming out. So I don't know how many of our group members have seen this. There was a new, in pediatrics, I say new, this is I guess June, but there was actually, we talked about prams earlier. In Georgia, they have prams for dads. And so that's where this data came from, is we actually had 250 fathers there surveyed 2 to 6 months after the baby was born on safe sleep and infant breastfeeding practices. So, of course, as I've said before, breastfeeding is great in terms of a protective factor to reduce SIDS death. We know that, and it's one of those things we love to promote. So these do often go together. So here's some very interesting data. So fathers who wanted mom to breastfeed, 95% reported initiation and 78% at 8 weeks. So you see a little drop, but not a very significant one, compared to what is a pretty big drop here. Those who were not supportive, so initially mom breastfed 69%, and then that was way down at 33% 8 weeks later. So that really was shocking to me. And again, to me, the takeaway on this, I think, is just how big of an influence dads can have in both directions in terms of both safe sleep practices and breastfeeding. So there's a lot more to dig into that we obviously don't have time for to go through in the article, but I wanted to share what was, I think, one of the bigger headlines. So do go through and read that when you have a moment. But I think the thing I wanted to talk with everyone about here is the good news is that we actually do have some materials that we put out fairly recently. Hopefully these are going to go to print and I'll have them in hand. This is on the website right now, but I don't have it printed just yet. So this is our toolkit for new dads. And you'll see here in the screenshot that it actually has a component on how new dads can help with breastfeeding. So both breastfeeding and infant safe sleep are covered in our toolkit. So that is the good news. I don't think that's where the conversation stops. I said this on our work group meeting just last week that I think we need to talk about what else we could do. But I'm glad to say that at least we have a good starting point for those conversations. So if anyone interested, just go to that link, and actually Kamisha's put it in the chat as well. Thank you. Okay, take one hat off, put the other one on. Now we're going to talk about maternal mental health. That's the other work group that I co-lead. Okay, for anyone who's not aware, we did this last year. We actually did it the year before, but last year was the first in-person training event that we partnered with PSI on in a while. So PSI is, we love acronyms here at the health department. So let me break that down. That's Postpartum Support International. They, of course, are the national leader when it comes to educational and perinatal mental health. And they have a certification course that actually is a 3-day training. It's technically 2 different trainings that are often partnered together. One is called the Components of Care for Perinatal Mental Health, and one is Advanced Perinatal Mental Psychotherapy. Now, these are great because these are trainings we know that are very, it's the only certification, let me put that out there, for at the national level on perinatal mental health. So we have, as we did the year prior, and the year prior to that virtually, offered scholarships for those, and we did prioritize, as we did the year before, those in rural areas, for clinicians, mental health clinicians, to come and get this training so that we can increase our pool. You know, when I started in this role 7-something years ago, I heard pretty frequently from physicians, well, I can't screen for postpartum depression or anxiety because then I have no one to refer to. So we're trying to get rid of that as a reason not to refer. And I will say this, that we've made some great strides. I mean, I could barely needed both my hands to count the amount of folks certified when we started this. And now we're over, I think, 80 total. And we'll be even more after this year. So I'm really excited. This year it's October in Norman. So that'll be the 11th, 12th for the first training and the 13th for the final one. These are, I think at this point, all full. So I'm not actually asking for anyone to apply because we filled all our slots. Now, I will clarify, if you want a private pay, you can still register. We just don't have any more scholarships. But that is exciting. I wanted to share. Okay. Additionally, one of the other big events that we have each year for awareness around maternal mental health is the Climb Out of the Darkness. This is actually a national event, typically held in June. And they do that even though Maternal Mental Health Month is May, and the first week in May is sort of when that's celebrated. Typically, the climb has been in June because that is seen as the sun and where the sun is at in relation to that being the brightest, and climbing out of the darkness is sort of the metaphor. This year, that's changed so that we have a couple different, nationally, there are 2 different dates. So there's that are doing this in June, they're in October. Here, for anyone who was there, I don't know if anybody was there that's on the call today, it was hot. It was hot and windy. And so the committee said, okay, let's go to October next year. That's an option. Hopefully it'll be a lot cooler. It's also moved just a little bit further north to Bluff Creek. We were at Lake Hefner last year. So Bluff Creek Park, address is on the screen. Just go through to the Facebook page if you'd like to register. The great news about this event, I'm not here to promote the fundraising component, just the awareness, but the good thing to know is that the money that is raised will be at least going some of that to the local chapter, which we didn't have. Some other events don't have that, so I'm really glad to see that. Okay, another big thing that I'm really excited about. Some of you may have heard me talk about before that there has been really at least a year, I think, an effort, maybe even longer, to put out, ACOG has talked about putting out a training module on addressing perinatal mental health in the obstetric setting. And that is finally here. So for anyone who doesn't already know, this is available for free. And there's 2 credits. Oh, thanks, Aisha. She put the article in the chat box. It's a really good article, so please do check it out. So this here is free, and they're saying May. So this has already been out for since May, but May of this year through March 1st of 2025, it'll be completely free, and talks about the patient pathway, recognizing the importance of screening and how to address intrusive thoughts and self-harm. So pretty excited to see that's come out. I've gone back and forth with some of the folks on this committee about, hey, when are you guys going to put it out there? Because I knew it was coming, and it's finally here. So follow that link to the module. I think that is all from me today.
Great. Thank you, James. That was some exciting information, and also to the maternal mood disorder and safe sleep work groups. You've done a lot of good work. Next, we have injury prevention. So I believe Alicia Brandy, are you taking the lead?
It'll probably be me. Alicia Lincoln. Let's see. There he goes. Okay, so I think many folks know, but on July 5th, our work group met. We said our farewells for Lisa Rhodes, who had led our work group since the inception of Preparing for a Lifetime and the infant injury work group. So we were sad to see her go. That does mean there's an opening if anyone is interested in helping Brandy and I co-lead this group. Over the summer, we had a series of social media and radio ads focusing on drowning prevention. And also in April, we had the norms of infant crying. So you may have heard some things on the radio or seen them if you were streaming music via various apps. The Injury Prevention Service did complete their drowning prevention website. It's got a lot of great resources. So if you need those or are interested or want to direct families there, please do so. We are working on completing our purchasing process so that we can continue to offer in hospitals who are participating, the norms of infant crying and the period of purple crying information. And we're in 42 delivering hospitals right now, and that's held fairly steady throughout the last 5 or 6 years. So we are in the process of updating our website. I know work group members have been sending feedback, and so I appreciate that. We had several work group members who participated in the OKC Fireman's 5K that was in August. And yeah, I wish they would move that to October, James, because it was a hot walk. But totally worth it because they use that to provide smoke detectors for families in need. Let's see, the work on the grandparent toolkit continues. So hopefully by the time this group meets next, we'll have a lot more to say about that, but we've got subject matter experts who are working on the various components and modules. And James and I met with communications yesterday and project management to kind of finalize to work on finalizing some of the deliverables that we need help with from our communications team. And for those of you who are familiar with the Good Health Handbook, it has been revised. It has been uploaded online, and county health departments, child care facilities, and elementary schools are all getting a copy. If you would like a copy, let me know or Peggy Byerly know, and we'll get one sent out to you. It's a great resource. It has lots of illness and injury prevention information for our young children. And the next meeting for infant injury prevention is October the 4th at 2:30 via Teams. So you're welcome to join us, and thank you.
Thank you, Alicia, and Injury Prevention Work Group. All right, and next we have preconception, interconception. Jill?
Yes, good morning. I just decided I'm going to have to up my game a little bit because James has some fancy slides with pictures and everything, and I've just been updating the words, so we'll have to work on making this exciting. So for the preconception, interconception work group, we supported for several years Medicaid expansion whenever we had the opportunity. And now we're applauding the extension of postpartum care for 1 year. As we found out with our maternal mortality review committee, that not all of our deaths occur in the typical 6-week postpartum period. And so having extended care for these moms hopefully will address some of the issues with access to care when our moms lost access after that 6-week period. So we'll be interested to see the uptake on that, as well as Medicaid expansion, where we know that just because the insurance component is there does not mean necessarily that people will take advantage of it for various reasons. And in some areas of our state, we do not have any women's health providers. And so people have to travel a significant distance, even if you have insurance coverage or Medicaid coverage. So we're waiting for some data to show us more about those expansions and how effective they are being. In the process, we identified the fact that we still had a gap. The typical Sooner Plan Medicaid benefit that has been in place for, I can't remember how long, was going to be phased out. The Healthcare Authority had plans to phase that plan out, which just covers family planning services for people that don't qualify for the full Medicaid benefits, because they felt like expanded Medicaid would cover most of the people that were currently covered with Sooner Plan. But we did identify a gap, and so we've been working to continue Sooner Plan, but to raise the income level to 205% of federal poverty, which is what the other expansion plans with the level that they're at, and hopefully catch some of those people that still don't qualify for full benefits, but could benefit from having coverage for family planning services. So that's in the process. And hopefully we're looking at a start date of January of 2024 for that. So keep your fingers crossed, and hopefully we'll have more options available. As far as messages, we also have some messages that we've been putting out through Cox Media. We have the preconception messages that are, I'm kind of amazed. Some of the PSAs we developed several years ago and some of the streaming social media messages are more current, but we are still getting a lot of traffic and good click-through rates on those ads. So I'm amazed every month that we get our report that we don't have to do anything to update these yet, because they're still reaching the intended population and getting some messages out. So that's pretty exciting. And we have a new set of messages that was just finalized on aspirin therapy in pregnancy, which we're promoting aspirin therapy with a project with OPQIC and other various partners, George Kaiser Foundation and March of Dimes and other partners. I probably forget somebody, but we're promoting aspirin therapy for the prevention of, to help prevent preeclampsia during pregnancy. And Southern Plains Tribal Health Board is also taking some of our messages and adapting them to better meet the needs of our Indigenous population. And so I think we've come up with some great messages, and so I'm excited about all that. Also, our Southern Plains partners are working on an Indigenous toolkit so that it's similar to the Preparing for a Lifetime toolkit, if you've seen that, with messages, similar messages, but again, adapted to be more relevant to our Indigenous population's needs and messaging. So then just a quick update on our projects through the Maternal Health Innovation Grant. We continue to support the STAR Clinic, which provides access to care for pregnant individuals with substance use disorders and mental health disorders. We also continue our project with Cherokee Nation, which we have an MFM clinic that's embedded within the Cherokee Nation Health Center, and that the need for that has grown, and they're looking at needing to expand. They do one telehealth day and one in-person visit day, and they're looking to expand to an additional telehealth day. And they're doing that in connection with the Perinatal Center and Dr. Stanley's group. So that's going very well. I already talked about Southern Plains. Our prenatal clinics within the county health departments are going great, and we just added prenatal services in District 6 in Holdenville, and so we're excited about that. And then I heard on a meeting yesterday that District 3 is planning to start providing services in October, so that's great. Oh, I have Chest Health on the end of that. We're expanding Chest Health to Tulsa and Oklahoma City. Those are our contractors for MCH services, and we're working to get that going. And then we have Project Echo, which is a virtual platform where we hear about information about taking care of pregnant women. It covers a lot of different topics related to prenatal care and postpartum care. We meet on the first and third Thursdays, and then we usually have a case reviews, and they're always looking for cases. So if you take care of pregnant women in any way, and there's any case that we can review, it doesn't have to be complicated. It just has to be an issue. We just want to talk about issues that come up in real day life and how issues can be addressed. Our last echo was on Children First and Parent Pro programs, just to educate the people that were on the echo about the services that were available. So, and I just want to say that we're always looking for community events where we can get some messages out, some preconception, interconception messages out about access to care and about being healthy before getting pregnant. And so if you have community events where we could possibly share some information, when our work group would be happy to hear about those. As far as the Maternal Health Task Force, our Access to Care work group has decided that we're going to help partner with Work Group D on identifying current resources for midwives and doulas and expanding our workforce in that area. And then just a quick run through, in case you have heard or haven't heard, I don't know how much you have or have not heard, but we did lose our Title X grant for funding family planning services, but we did receive state funds from the legislature to continue the program at the same level it was. We have a few changes in the program, but basically it's services are still being provided. So that was good news. Our work group also looks at fatherhood projects, but James has already talked about fatherhood. We also collaborate with child and adolescent health staff, and we appreciated their input into a brochure that was created recently to hand out to teens coming into the health department that are not pregnant but now need parental consent for family planning services. Before, we provided confidential services to adolescents, which we can't do without our federal funding. So we thank the child and adolescent health staff for helping us create a brochure that was appealing to our adolescent population. We continue to work on publications with Aisha's staff for PRAMS data. And we actually have a syphilis task force meeting right after this to address our congenital syphilis, the rise in congenital syphilis in Oklahoma. Oh, I already talked about community events. So we're always looking for opportunities for community events. And I think that's all for us.
All right. Thank you, Jill and Preconception Work Group. Next, we have the Tobacco Work Group. Crystal?
Good morning, everyone. My name is Crystal George, and I'm excited to say this work group is progressing. We're still getting our feet underneath us and still helping to identify needs. But the last time we met, we've decided that we're going to do some infographics. We're going to build some infographics on just the general dangers of smoking. We're going to build an infographic on secondhand smoke. And then I'm excited to say we're going to expand to third-hand smoke as well. So our goal is to have these done within the next year. So those are our big highlights right now. Sorry, I don't have any slides or anything fancy like that. Just some quick highlights from what the group's working on. If you are interested in attending the work group, our next meeting is October 5th at 10 o'clock via Teams. So you're welcome to attend.
All right. Thank you, Crystal, and the Tobacco Work Group. And next we have Prematurity. Barbara?
Good
Are
morning.
you speaking or Lori? Okay.
Good morning. How is everyone this morning? Exciting to share some actual activities. Do you have our slide, Kamisha? Here we go. We are hopefully going to be taking some, well, we will be taking some action, which will also lead to an indirect decrease in our preterm birth rate. This is through our low dose aspirin initiative to reduce the incidence and severity of preeclampsia so that all of those eligible to receive aspirin during pregnancy will receive a prescription and be followed up on to ensure they're taking the medication so that we should have a decreased incidence and severity of preeclampsia, which is one of the leading causes of preterm births, having to induce or do a C-section because of preeclampsia. So I'm going to introduce our newest staff member, Melissa Ward, who is leading the low-dose aspirin initiative, and Melissa will go over information on this slide.
Thank you, Barbara, and nice to see you all. Yes, this is my first time on this meeting, so it's exciting to see some of the different projects you all are working on. So like Barbara said, we just launched our toolkit officially. I guess I'd say it was last week. And the toolkit is designed to do a couple of different things. One, to educate providers on what patients would be eligible for low-dose aspirin. The guidelines have changed since 2021, and it includes a large, well, it would include, based on these new guidelines, a majority of pregnant individuals in Oklahoma. And so our goal is really just to improve health outcomes and health equity in pregnant populations. And so low-dose aspirin has the potential to do that just because it can improve blood flow and oxygenation in the placenta so that pregnant patient can stay pregnant longer. And it helps reduce some other things like intrauterine growth restriction and low birth weight. So we're really excited for this to launch. So again, that first initial part of the toolkit is targeted towards providers and also clinicians who may also be doing screening for low-dose aspirin. And then I've also created patient education materials. We know that health literacy is a barrier to a lot of patients. And initially, when you go to those first prenatal appointments, you're very overwhelmed by what you're being told by the provider, and there's a lot of excitement, and you're seeing ultrasounds, all that kind of stuff. But sometimes patients tend to forget everything that was told to them, including aspirin recommendations. There was actually a paper that just came out last month that said a majority of patients didn't really remember that they were even told to take aspirin, even if they were a high risk, or, and this is specifically too with moderate risk patients. And so we created patient education materials that could be distributed to those patients on the day that they're told to take aspirin. That just kind of explains a little bit more about what aspirin can do for them. They can also self-screen themselves for aspirin eligibility. So lots of great things, and that's all available on our OPQIC. I messed up our acronym. Our website. And then we also have a live binder that's available for patients to use as well, or patients, well, providers specifically to use to access those materials as they see fit. We also met with the group at OHCA to come up with measures. So our leading measures are going to be script count claims per month. So we are recommending that providers issue a prescription for low-dose aspirin because of a number of reasons. One, it makes it affordable to the patient because those prescriptions for the low-dose aspirin are free to patients for the prevention of preeclampsia. We're also doing that so the patient has specific instructions on how to take that medication. And then also it just kind of gives a little bit of peace of mind to the patient that they're getting it from a pharmacy, so to say, instead of being told to take it over the counter. Sometimes you can forget that if you got that recommendation to take aspirin, that you're supposed to go buy it, and then you get to the store and are overwhelmed by the sheer number of choices for low-dose aspirin available, and you kind of wonder what is better than another. So it just takes out that confusion element of it. So we are monitoring those claims per month. And then we also are going to be evaluating unique prescribers. So are we seeing an uptick in the number of prescribers that are prescribing it? Right now, the last data we had that was that only 440 prescriptions per month were being filed through Medicaid claims. So with about 50,000 births per year and half of those being Medicaid patients, there should be a lot more. The latest estimate I had heard is about 70% of pregnant Oklahomans could benefit from low-dose aspirin. And so we know there's potential for more prescriptions for that coming out. Some of our lagging measures are just number of preeclampsia cases that we see per year, gestational hypertension, diabetes, chronic high blood pressure before pregnancy diagnosis. So we'll be monitoring those as well. But the data, of course, is not as forthcoming with that just because of how claims get filed with Medicaid. Recently, this initiative has been published in multiple newsletters. It just came out in the Take Control Initiative newsletter, and it was in the provider and member newsletters for Sooner Care, providers and patients. And then it is in the Oklahoma Physician Assistant newsletter, the Oklahoma Nurses Association newsletter, County Health Department, and possibly the State Board of Pharmacy if they approve it for their quarterly newsletter that comes out in October. We also have a number of speaking engagements. So I just presented to TBEI, which is the Tulsa Birth Equity Initiative, last week, and I presented to a group of doulas because we know they are critical for just being part of that patient relationship and encouraging patients to advocate for themselves and ask questions of their providers. We also I'll be presenting to the Oklahoma Pharmacists Association Live CE event that will be in December. We have our OPQIC Summit that's coming up, and then we just received notification that we will have a spot at the ACOG District 7 conference to do a brief presentation on our initiative. And again, this project was funded by the George Kaiser Family Foundation, so we are very appreciative of them supporting us in this initiative. That's all I have.
Thanks, Melissa, so much. And so if anyone, I put the link to our low-dose aspirin page in the comments, and feel free to use those. And then, like Melissa said, we do have information. If you have newsletters or anything that is going out, we can put information about this in those publications. Also, Melissa is available for speaking engagements. Please use these materials if you have community events and things like that. And we're happy to attend to help promote this low-dose aspirin initiative. And it looks like Joyce is showing some of the health department materials that are also available. So I'll turn it over to you, Joyce, to talk about these.
Okay, yes, I think Kamisha just put up, this is the low dose aspirin initiative PSA that we worked on with the work group to get the news out. It's running on Cox Media currently, and just encouraging women to ask about low dose aspirin and how it may be able to help them with their pregnancy and some of the indications for that. So this also will link to OPQIC toolkit for the low dose aspirin toolkit that was Melissa just talked about, and other items from March of Dimes, and educational materials available. So this is another resource to try to get that message out about low dose aspirin to help the births and the maternal health for our women in Oklahoma. And it's available in English and Spanish and currently running. So thank you to the Okay, so I think Kamisha just ran that. I think they're reversed though on the English and Spanish, but yes. So those are the ads. I think we're having some technical difficulties. These are the ads, the display ads. That was the PSA. These are the display ads also to get the information out in relation to asking about aspirin to assist in the matters. So these are currently running, as I said, and are out. And we hope to correlate with the Ask About Aspirin campaign that is currently running both for the prematurity work group, the full campaign, and maternal health task force. So we, like I said, this is affecting, as Melissa said, about 70% of our pregnant population based on the last numbers available. That low dose aspirin could help with better pregnancy outcomes. Okay, thank you to that work group. And next we have the breastfeeding work group. And before I turn it over to that work group leads, I do want to introduce Amanda Parsons. Amanda is our new nutrition and lactation coordinator for the Maternal and Child Health Service. So welcome, Amanda. And this will be her first meeting as a lead in this work group, along with Becky and Adriana. So I'm going to welcome Amanda and turn it over to Becky, Adriana, and Amanda.
All right. Thank you for that. And yes, we are excited to welcome Amanda as well. And Adriana and I were kind enough to put together the slides for today and give Amanda a little breathing room before we pile that stuff on top of her. So, Kamisha, are you advancing slides? There we go. Okay, so yeah, updates from kind of several of our entities, of course, from the Oklahoma Breastfeeding Resource Center. We continue to do trainings. We have our 2-day training that we do quarterly. We do it twice a year in Oklahoma City and then twice a year in Tulsa. So our next one is in Tulsa, November 29th and 30th. So that is a free training. And then just a reminder to this group too, that we do have an online breastfeeding session for families. So that helps with that prenatal, evidence-based prenatal education. And it's an online interactive little course, and it takes 45 minutes to an hour, and lots of pictures and videos. And the Spanish one is all in Spanish. The videos are all in Spanish as well, and there's excellent videos there. So next slide, Kamisha. Thank you. And then under baby friendly, we are excited to announce that Stillwater Medical Center is embarking on their baby friendly journey. And so our first new hospital really since COVID. So we're very excited about that. And then we also had some recent contact with Choctaw Nation, our last tribal hospital. And so we actually have a leadership meeting scheduled with them next month to hopefully bring them on board as well. And then otherwise, any of our hospitals that are currently designated, they go through redesignation every 5 years. So we have a good crop coming up that will be due over the course of the next year to year and a half. So excited for them. And then just to save the date, that we are busy planning our 12th annual summit, which will be Friday, March 1st next year. And we'll be trying out a new location, but one that OPQIC has had good success with as well. So next slide, Kamisha, thank you. And then, of course, a few updates from COBA, and I know Heidi's on here as well. And Heidi was very busy helping get, of course, August is National Breastfeeding Month. So we had some National Breastfeeding Month proclamations from both Oklahoma and Tulsa counties, and then also one that Mayor David Holt signed for Oklahoma City. So we were very excited about those. And COBA also did a series of videos. So those Heidi, maybe you can put in the chat box where they can access those videos. So there was a theme each week for National Breastfeeding Month. Like the last week was Black Breastfeeding Week, and so COBA tried to have a little short video interview of a breastfeeding mom representing each of those weeks. But COBA is hosting its first ever really major conference, and Maya Bowman, an IBCLC out of Ohio State, is coming to do her gentle manual therapeutic techniques in lactation, and this has been kind of on request for quite some time. And so, and that's actually coming up next week, and there are still seats available. So if people want to sign up for that, maybe Heidi, you could put that link in and then the slides, we had the link there as people get the slides after this meeting today as well, if you want to register. COBA also hosted a free webinar during National Breastfeeding Month that you see here on the right, Dr. Todd Wolin out of Pittsburgh, and that recording is available. He's a very dynamic speaker, and it was a very enjoyable and informative presentation. So another free resource. And of course, COBA continues to offer scholarships to increase the number of IBCLCs that are representing either minority or kind of underrepresented groups. And so we were excited to announce two recent certified IBCLCs, Kristen Booker out of Chickasaw Nation, and then Keisha Sanders, you see there on the left. And then a new project working with the Chickasaw Foundation with a grant from the Chickasaw Foundation and COBA's partnership with Chickasaw Nation Medical Center to help set up a breast pump loaner program for women that are underinsured and may not otherwise have access to a quality electric pump. So next slide there. And now a quick glance at Oklahoma Mother's Milk Bank. That's a picture there on the left of at least the pasteurizing lab of our, still somewhat new. We moved last year and still on the OUHSC campus, but much more space. And we are excited, to announce that we have 32 milk depots, 24 of those in Oklahoma, and several in Kansas, since we're now, we had the milk bank in Kansas City that closed during COVID. And so we are, supporting several of the hospitals that milk bank previously serviced. So, so you can kind of see there on the map where our milk depots are currently located. And for those of you that might not be aware, Milk Depot is really just a local drop-offs location. So if a donor lives in Ada, she doesn't have to come to Oklahoma City to drop off her milk. She can drop it off there in Ada. So, and the milk bank will work with whatever organization wants to be established as a depot, and the milk bank provides the freezer and does some training and so forth. And we'll send our pink milk mobile to pick up the milk. And then as you see on this page as well, just continuing to raise awareness of our outpatient services through the milk bank, since we did get the long-awaited Medicaid coverage for pasteurized donor milk for babies with a medical need in the home setting, so after hospital discharge. And we are still, working to raise awareness and meeting with, neonatologists in different NICUs as well. So if there's a baby, in the NICU that, they can't transition to formula and they, really want to send that baby home on donor milk for a little bit longer, then they would, be able to do that. And we also have, this kind of came up during the formula shortage that we started a bridge program. So in this program, someone who maybe has a short-term need for donor milk, trying to, build milk supply, maybe the mother had gestational diabetes and dealt with low blood sugar in the baby in the hospital, and then her milk is increasing a little more slowly and just needs, a small amount of donor milk to kind of bridge the gap. So those requests, we will make every effort to fulfill, and those do not require a prescription. And you have information there, and then that's a QR code. So the a person a family who may need a donor milk in the community can scan the QR code and kind of start the little screening process there. And the pictures over here on the left, oh, go back for just a second there, Kamisha. Yeah, so Holly Skinner is our longtime donor coordinator, and then Christina Washington is newly transitioned into our outpatient and depot coordinator position, and working with Holly to, really help build that outpatient service. So we are excited to have those two ladies in charge of that. And now you can go to the next slide. And there's the Pink Milk Mobile. So if you see that out and about or on the turnpike to Tulsa or something, take a picture and send it to us. And then we're very excited to share the pictures here of our Silas Murphy Memorial Wall that just was completed this summer in our new location. We contracted with a local artist who did a fabulous job. And as you can see there, all the butterflies and little plaques. So any of our bereaved donors, so a milk donor who may have, lost a pregnancy at 20 weeks and decides to pump in memory of her baby and donate that milk, or someone who, had a stillborn baby at term, or had a baby, die during infancy, as we heard, of our infant mortality rates. So if those mothers decide to donate milk, those donors have a very special place in our hearts at the Milk Bank, and also now on our lovely new memorial wall. And Silas Murphy, the name for the wall, Silas Murphy's mother is here in this picture with her husband and two later healthy children that she had. She was actually, ironically, our very first approved donor for the Milk Bank back in 2013. Yes, 10 years ago, when the Milk Bank was just starting to screen donors. And she was our first approved donor who had lost a baby at full term, and but went on to have two later healthy babies and became a donor with all three of those. So we were very honored to be able to name our wall in memory of her baby as well. So anyone that wants to come and take a tour of the Milk Bank, absolutely let us know. We love to take groups on tours, and you can see, the memorial wall, and of course see pasteurization going on as well. All right, next slide. And then since, yes, this has been our starting in August was our 10th birthday for the Milk Bank, and we are planning a big gala. Whoops, go back real quick. Last one there. Yeah, big gala, first time to do something like this, but to celebrate 10 years of saving lives, and that will be Saturday, March 2nd. So we try to partner it with the summit when people may be coming in town for that. So that's going to be on Saturday, March 2nd at the Skirvin in Oklahoma City. All right, next slide, and then I think I'll turn it over to Adriana.
Let me get off the mute here real quick. Thank you. Yeah, I just wanted to go ahead and jump in just with a few WIC breastfeeding updates, as well as concerning OSDH and MCH as well. But we have recently updated the Oklahoma Lactation Resource Guide. This guide can be found on the Oklahoma State Department of Health Breastfeeding and Information Support website. And earlier, Becky had mentioned we're really trying to increase the number of IBCLCs in Oklahoma. Currently, there are 210 statewide. Not all are listed in the guide. We did send out a survey via Qualtrics, and our response rate was around 63%, but we're looking next time to increase some efforts on reaching LCs. There are some that may be retired or maybe not practicing, so there's some reasons why they may not want to be listed, but next time around, we're going to try to focus on how we can get more responses and listings here. So you can find that on the resource page of the Breastfeeding Support website. And I just wanted to mention as well, with trainings, WIC has, and I didn't add a bullet on this one, but we did in March have the WIC Breastfeeding Symposium and State WIC Conference. We had a really great turnout for that. We co-facilitated with Nursing Service, and we had over 800 statewide people attend the the Nursing and Nutrition WIC conference, our breastfeeding symposium, which was the last day, had around 200. So it was still a good turnout, but those sessions were more focused on breastfeeding, around postpartum and perinatal disorders, and there was just a lot of really great information shared. So we were patting ourselves on the back after that training, but we have also recently finished our WIC breastfeeding educator course. That was in June. We had 139 staff attend that. That was facilitated by Glenda Dickerson, and she's done that for WIC for many years. And Glenda has recently announced her retirement, so we're a little sad about that. But we will be looking for speakers to facilitate the breastfeeding educator course in the future for us. But great training that was held in Oklahoma City. And then our WIC certified lactation specialist course that was just completed as of this week. That was a 40-hour workshop facilitated by a lactation education consultant group. It is a certification course. And we had 39 staff complete that. So the CLS is a stepping stone to the IBCLC. So it's really exciting. You know, we're having staff complete this, and some may decide to go on and get their IBCLC. So there's just more added breastfeeding support in Oklahoma for the families that really need that now. And another honorable mention is that we have had 3 of our WIC clinics receive the USDA Food and Nutrition Service Gold WIC Breastfeeding Awards. Those awards went to NSO, Variety Care, and Oklahoma City County Health Departments. So some of the requirements are that the WIC clinic must have operated a peer counseling program for at least 1 year and have to have met all of the required core components of the WIC breastfeeding model for peer counseling. So those can be found on our WIC website if you're interested and want to look at that. But that designation is good for 4 years. So I'm really excited for them. Next slide. Thank you. So I also wanted to show a little photo here on the left of the lobby signs that our Office of Communications has helped redesign. This is something that you may see when you go out to our county health departments and independent WIC clinics. It's bilingual, and it's replaces the older banners that said breastfeeding friendly zone, but it's a way to let our participants know that come in that this is a place where breastfeeding is welcome, and that we do have a private area if that's requested, so or preferred. Not every clinic, and I've had questions, we don't have a breastfeeding room, so what do we do? But you know, if there's an empty nutrition education classroom or conference room or office or space other than a restroom that a mom could utilize to breastfeed. So that's all that means. And then when you do scan the QR code, that takes you to the OSDH breastfeeding information website. And Becky had talked a little about World Breastfeeding Week, and I wanted to highlight a couple of the efforts, the statewide efforts that have taken place in August, and those are on the next slides. So Variety Care, one of our winners, if you remember, of the Breastfeeding WIC Breastfeeding Awards, they had some wonderful celebrations throughout the month of August. They hosted some receptions for moms where they provided refreshments and also education and information from community organizations such as True Dads, the Oklahoma Mother's Milk Bank, and Safe Kids. They also had some activities for the moms that came in their kiddos and babies. They had a breastfeeding mini photo shoot session. And that was really a really great highlight of the event. They also involved their staff, and in this photo, staff were wearing all pink shirts on this particular day to represent how breastfeeding decreases the risk for breast cancer. Next slide. And Variety Care, they also did a door decorating contest, and here's a few photos of the doors. And so this was really great, especially with in August and immunizations going on and people coming through the clinic. It was a great way to increase awareness and provide a little bit of education along the way. Get a next slide. And then this is a few of the pictures of some of the events. They Tulsa City County, or I'm sorry, on the left is our NSO clinic. They had hosted a reception as well and a luncheon for moms and babies. They had some really great breastfeeding promotional items that were raffled off. They played a breastfeeding bingo game. It was a lot of fun. I actually got to come out and visit that particular day because they did have a wonderful catered luncheon, which was really nice from TED. So I'm not turning down any TEDs. And then in the middle is Kingfisher County Health Department. They had the farmers market and they had a breastfeeding booth with pamphlets, information, breastfeeding booklets. There was also a Spanish interpreter present. And this was along with their Crazy Days that goes on in Kingfisher, which is this farmers market. So it was they had a really great success. And then on the right is Tulsa City County Health Department. They had their annual Mother's Gift breastfeeding reception, and they had some photo booths. They also had tables set up with helpful information for each stage a parent may be experiencing in their breastfeeding journey. I believe that's the last slide is welcoming Amanda, which Joyce already did. So we're excited to have her as part of our team now. Thank you.
All right. Thank you, ladies. And as you can see, breastfeeding work group is very busy and a lot going on there. So thank you very much. I think this comes to the end.
There is one question.
There's a question.
They want to know where to
Okay.
get the lobby signs from. The WIC lobby signs. Where do they order those from or get those from?
Oh, okay. Yes, those were drop shipped to clinics. Each clinic did receive a few of those posters. But if you're interested, I will put my email and I will get you in touch with who we can get so we can get those mailed to you.
Great. Thank you, Adriana. All right. Any other questions? Okay. Well, great month for September. And as you can see, great progress being made for the year. For October, we have some additional acknowledgements that will be coming up that are related. Pregnancy and infant loss awareness, of course, SIDS Infant Safe Sleep Month, and also National Midwifery Week. So please remember these important awareness as we move into October. Then before I do a closing, I just want to make sure, are there any announcements from the work group that they would like to make to the group?
Yes, I would like to announce, this is Barbara, that the OPQIC Summit will be held November 17th. We've sent out an email. We'll be sending out another one. So you can, I put the link in the chat to go to the OPQIC website to register for our summit on November 17th.
Great. Yes, this is an excellent summit. So please plan to attend if you can. Always a lot of really good information and additional items in relation to what's going on in Oklahoma to improve maternal and infant health. So in closing, I just want to say,
oh, Joyce,
there's Becky.
I had one quick. Yeah.
Yes, Becky.
Oh, just a quick announcement too, that we do have a full-time position for an IBCLC in the OU Health clinic that just got posted this week. So if you know any experienced IBCLCs, that would be a Monday through Friday full-time position. So
great. Well, let Becky know if you know anyone good that could fill that position for them and assist in those efforts. Okay, well, in closing, because it's that time, I'm just going to say, as you can see, we have a lot to celebrate. Good news in relation to efforts to reduce infant mortality. The rates are continuing to be at historical lows, although we still have work to do. And as you can see, our work groups are busy doing that. and continuing to make those efforts to continue the great work. So thank you, everyone. Kudos to each of you for the great work that you are doing in this regard. Keep it up. Thank you and have a wonderful day.
Thank you.
Bye, everyone.